I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to this solid anatomy video on the inguinal canal. Now, the inguinal region is the lower lateral abdominal region that includes the inguinal ligament and the inguinal canal, and this is the most common area for hernias to occur. We're going to talk about inguinal hernias a little bit later in the clinical correlation. But the inguinal region is rather complex, and it's helpful to discuss the embryological development about it just a little bit in order to understand the anatomy. So let's begin with the related embryology, and then I'll turn it over to Dr. Phelan later. So after about 8 weeks of development, the undifferentiated gonads of both sexes lie on the posterior abdominal wall in vertical folds of the peritoneum. And from each fold, gonadal ligaments or suspensory ligaments form, which attach to the upper and the lower poles of the gonad. We call these poles the cranial pole up near the head and the caudal pole. So the caudal ligament, which is attached to the inferior or caudal pole of the embryonic gonad, is called the gubernaculum, and it extends to the labioscrotal swelling in the inguinal region. And then the anterolateral abdominal muscles develop around the gubernaculum, resulting in a narrow inguinal canal occupied by the gubernaculum that runs through the muscles, but not through the peritoneum. And just to be clear, I'm going to talk about what's happening on one side, but under normal circumstances, all of this is happening bilaterally. So that's the gonadal ligament on the caudal pole of the gonad. Now, what about the ligament on the cranial pole? In the male embryo, androgens cause the cranial gonadal ligament to regress and just disappear, while the gubernaculum thickens. Now, as the embryo enlarges and the trunk lengthens, the gonad, which we now call a testis, is held in the inguinal region by the gubernaculum. And at about the third month of development, an outpouching of the peritoneum called the processus vaginalis forms. And it begins extending inferiorly through the inguinal canal into the scrotal swelling anterior to the testis. And at the same time, the testis is descending by a mechanism that's not really well understood. It's descending through the inguinal canal into the scrotal swelling posterior to the processus vaginalis. The testis and the processus vaginalis force the inguinal canal to sort of widen and dilate as they pass through the canal, dragging extensions of the abdominal muscles into the scrotum. And that ultimately becomes the coverings of the testis and all the associated blood vessels and the ducts. And this collection of structures is called the spermatic cord. Now, when development is complete, the gubernaculum is very short, and it anchors the caudal pole of the testis to the fascia of the scrotum, and it's referred to as the scrotal ligament. Then the processus vaginalis becomes obliterated around the time of birth, except for a very small double-layered sac of peritoneum within the scrotum called the tunica vaginalis that covers the anterior and medial surfaces of the testis. So that's the male. Now, in the female embryo, you have the two suspensory gonadal ligaments, one cranial, one caudal, and that caudal one is the gubernaculum. And then what do we say causes the ligament on the cranial end to regress and disappear in males? Well, that's the androgens. So in females, you don't have a ton of androgens, so that cranial gonadal ligament persists. Then the gubernaculum, instead of thickening, it attaches laterally to the primitive uterus. Now, as the female embryo enlarges, these ligaments are going to lead the ovary to its final position in the pelvis. And then what about the processus vaginalis? Well, just like in the males, in females, the processus vaginalis passes anterior to the gubernaculum through the inguinal canal into the labia majora, which is the female homologue of the scrotum. And normally, it becomes obliterated around the time of birth, leaving no remnant in the adult. While we're talking about the labia, I just want to point out briefly that labia majora is actually plural. Technically speaking, the singular would be labium majus. Now, when development is complete, we call the segment of the gubernaculum attaching the ovary to the uterus, we call that the ovarian ligament. And then the segment of the gubernaculum running through the inguinal canal from the uterus to the labia is called the round ligament of the uterus. The inguinal canal in the female is considerably narrower than that of the male because there's no spermatic cord passing through it. And then the cranial gonadal ligament eventually regresses and is replaced by the suspensory ligament of the ovary, which carries the ovarian blood vessels and suspends the ovary from the lateral pelvic wall. All right, that's enough embryology for now. So let me turn you over to our primary lecturer, Dr. John Phelan. He's going to continue discussing the inguinal canal.
The inguinal canal begins at the deep inguinal ring, an opening in the transversalis fascia, and ends about 5 centimeters distally at the superficial inguinal ring, a defect in the external oblique aponeurosis. Think of the canal as a tube running in the plane of the inguinal ligament. Its anterior wall is formed by the external abdominal oblique aponeurosis, while its posterior wall is just the transversalis fascia, the extraperitoneal fat, and the peritoneum. The floor of the canal is the inguinal ligament, while the roof is formed by the internal abdominal oblique and the transversus abdominis muscles. The genital branch of the genitofemoral nerve passes through the inguinal canal in males and females and provides sensory innervation to the skin over the scrotum and the labium majus. The genitofemoral nerve is a branch of the lumbar plexus of nerves, which will be discussed in the Solid Anatomy lecture on the posterior abdominal wall and viscera. The ilioinguinal nerve, another branch of the lumbar plexus, enters the inguinal canal distal to the deep ring and exits through the superficial inguinal ring in both sexes as well. This nerve contributes to the motor innervation of the inferior abdominal musculature and provides sensory innervation to skin over the lower abdomen and the upper thigh. In the male, the spermatic cord passes through the inguinal canal, while in the female, the canal is traversed by the portion of the gubernaculum called the round ligament of the uterus.
Let's pause here for just a second to talk about inguinal hernias. Now, we discussed abdominal wall hernias in the video on the abdominal wall, but hernias also frequently occur in the inguinal region, and they come in two main flavors: direct hernias and indirect hernias. So if the processus vaginalis remains patent after birth, an indirect inguinal hernia can develop. An indirect inguinal hernia involves the abdominal contents, such as intra-abdominal fat or a segment of the intestine, following the processus vaginalis through the deep inguinal ring into the inguinal canal. And sometimes that indirect hernia may continue through the superficial inguinal ring into the scrotum or into the labium majus in a woman. So indirect hernias follow the same path as that descending testis. So you can imagine these are much more common in males. Remember, the inguinal canal is much bigger in men, so there's more room for a hernia to develop. Now, on the other hand, a direct inguinal hernia does not pass through the deep inguinal ring into the inguinal canal, but instead it most commonly protrudes through an area of the abdominal wall known as Hesselbalch's triangle, which is bordered by the inferior epigastric vessels laterally, and the lateral edge of the rectus abdominis muscle medially, and then the inguinal ligament inferiorly. So this is how inguinal hernias are named. They either go directly through the abdominal wall or they go indirectly through the inguinal canal. Now, a direct hernia still will usually pass through the superficial inguinal ring, since the external abdominal oblique aponeurosis is usually too difficult to penetrate anywhere else. But normally it does not descend into the scrotum or the labium majus. So make sure you're aware of the difference between direct and indirect hernias. Direct inguinal hernias occur medial to the inferior epigastric artery, whereas indirect inguinal hernias occur lateral to the inferior epigastric artery. That's another topic that surgeons love to grill students on. So let's get back to Dr. Phelan.
The scrotum, like the labium majus in the female, develops from the labioscrotal swelling of the embryo. Deep to its skin, the superficial fascia of the scrotum is devoid of fat, but contains smooth muscle and is called the dartos fascia. Sperm are very temperature sensitive, so the dartos contracts or relaxes to regulate the temperature of the testes. In response to low temperatures, the dartos contracts, effectively shrinking the scrotum and bringing the testes closer to the warmth of the body. When the temperature of the testes exceeds that which is ideal for the health of the sperm, the dartos relaxes, allowing the testes to descend away from the body where the temperature is lower. The dartos fascia is continuous with Scarpa's fascia in the inferior part of the anterior abdominal wall, and with the superficial perineal fascia, or Colles fascia, of the perineum, an area that will be discussed in the Solid Anatomy Pelvis Lectures. The scrotum contains the left and right testes and spermatic cords separated by a scrotal septum found in the median plane. As mentioned previously, as the testes and processus vaginalis descend into the scrotum, they drag the vessels and ducts of the testes and extensions of the components of the abdominal wall with them. The extension of the external abdominal oblique in the scrotum is called the external spermatic fascia. The extension of the internal abdominal oblique is partially muscular superiorly at the level of the spermatic cord, but is only fascial at the level of the testis. These extensions are called the cremaster muscle and the cremasteric fascia. The cremaster muscle is a voluntary muscle that also reflexively, that is, involuntarily, contracts in response to stimulation of the L1 dermatome, which includes skin over the medial thigh. When the cremaster contracts, the testes is drawn up and out of the way of any dangerous situation that may be occurring in the vicinity of the L1 dermatome. This muscle is innervated by the genital branch of the genitofemoral nerve. The transversus abdominis muscle does not extend inferiorly enough to be stretched into the scrotum by the descending testis and processus vaginalis, so it does not contribute to the spermatic cord. The transversalis fascia, however, does contribute, forming the internal spermatic fascia. The peritoneal remnant of the processus vaginalis, the tunica vaginalis, has a parietal layer adhered to the deep side of the internal spermatic fascia, and a visceral layer that covers the anterior and lateral sides of the testis and part of the epididymis, which will be described shortly. The tunica vaginalis is only found at the level of the testis and is not a component of the spermatic cord. To summarize the layers over the testis: skin, dartos fascia, external spermatic fascia from the external abdominal oblique, cremasteric fascia from the internal abdominal oblique, internal spermatic fascia from the transversalis fascia, and the parietal and visceral layers of the tunica vaginalis from the peritoneum via the processus vaginalis. At the core of the spermatic cord are four major structures that also traverse the inguinal canal: the ductus deferens, which transports sperm from the scrotum to the pelvis; the genital branch of the genitofemoral nerve, which, in addition to providing motor innervation to the cremaster muscle, also provides sensory innervation to the skin of the scrotum; the testicular artery, which is a branch of the abdominal aorta; and the testicular vein, which drains into the inferior vena cava on the right side and the left renal vein on the left. The testicular vein begins in the pampiniform plexus of veins, a network of veins that wraps around the testicular artery and is thought to be involved in thermoregulation of the blood entering the testis. Countercurrent blood flow between the blood entering the testis via the testicular artery and the blood leaving it via the veins of the pampiniform plexus results in transfer of heat from the artery to the venous network. This process keeps the testis at the optimal temperature for sperm production. The veins of the pampiniform plexus coalesce into a single testicular vein superiorly. We mentioned earlier that the labium majus, which is the homologue of the scrotum, is similar to the male in that the gubernaculum is anchored in its fascia. However, the labium majus contains no extensions of the layers of the abdominal wall, despite the descent of the processus vaginalis into it during development. Thus, females do not have a cremaster muscle. Deep to the skin of the labium majus, however, there is a homologue of the dartos fascia of the male, which is called the dartos muliebris. Muliebris is Latin for womanly. The dartos muliebris is a very thin layer containing smooth muscle whose function, if any, is unknown. The testis is surrounded by a tough, collagenous fibrous capsule called the tunica albuginea, which is Latin for white tunic. The tunica albuginea sends extensions, or septa, into the testis that divides it up into lobules. The lobules contain Leydig cells, which produce androgens, and tightly coiled seminiferous tubules that produce and transport sperm cells. The seminiferous tubules end in a network of anastomosine channels called the rete testes, from which extends about a dozen efferent ductules. The efferent ductules carry sperm from the testis to the head of the epididymis, where sperm are stored. The tail of the epididymis is continuous with the ductus, or vas deferens, the muscular duct which transports sperm to the pelvis. For more information on the anatomy of the reproductive system, download the Solid Anatomy lecture on the pelvic viscera.
All right, that covers the inguinal region. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. All right, let's get started. First question, what is found in the inguinal canal? So you have the ilioinguinal nerve, and then in males you have the spermatic cord, or in females you have the round ligament of the uterus. Next, what structures run in the spermatic cord? We have the ductus deferens, or vas deferens. You have the testicular artery and veins, the cremasteric artery, and then the artery of the ductus deferens. You have the pampiniform plexus, and then also nerves and lymphatics. Next, what are the fascial layers surrounding the spermatic cord, and from where do they arise? So the layers include the internal spermatic fascia, which arises from the transversalis fascia. You have the cremasteric fascia, which arises from the internal oblique muscle. Then you have the external spermatic fascia, and that arises from the external oblique muscle. Next, which muscle is responsible for the wrinkling of the skin of the scrotum in the presence of cold? That's the dartos muscle. Next, what's the pampiniform plexus? It's a network of veins that drain into the testicular veins. Next, what's the difference between an indirect inguinal hernia and a direct inguinal hernia? So an indirect inguinal hernia is a protrusion through the internal or deep inguinal ring and also the external or superficial inguinal ring. And it goes into the scrotum and it occurs lateral to the inferior epigastric vessel, so it's outside of Hasselbalch's triangle. Then a direct inguinal hernia is a protrusion through a weak spot in the abdominal wall and then through the external or superficial inguinal ring. It occurs medial to the inferior epigastric vessel, so it goes directly through Hasselbalch's triangle. All right, we're almost done. The last thing here is the mock practical to get some practice labeling these images in a time setting. So label the images, then you're all finished. Thanks.